There's a mandated waiting period following a myocardial infarction where if you have a patient who may be a candidate for an ICD, you really have to wait that period of time before you can implant. So how do we mind the gap, so to speak? There's an editorial and a paper in the November 19th, 26th issue of JACC, and I am with Dr. Andrew Epstein, who is professor of medicine at the University of Pennsylvania and the chief of the cardiology section at Philadelphia VA Medical Center. So describe this study, because it's a large one in patients that you wrote about in JACC.
Yeah, thank you very much for asking about it. We actually, the genesis of this comes from my involvement with being a chair and co-chair of the guideline committee for the implantation of devices. And there is the 40-day waiting period post-infarction for individuals irrespective of revascularization, but if there has been revascularization, actually the waiting period is 90 days. So the question is if somebody has been saved from their heart attack by an intervention and care, we want to save them from sudden death also. And what do we do in this waiting period before appropriateness is deemed satisfactory for reimbursement, especially for Medicare and Medicaid reasons, before implanting a device? So I had the good fortune of Zoll, and I should, by way of disclosure, say that I have received honoraria from them, but the Zoll provided me with their database for the prescription of defibrillators in this first 40 days, in the first 3 months post-infarction. And these individuals were not randomized. We know the date of their infarction and their ejection fraction with some certainty, by virtue of the fact that for billing, they had to fit into the criteria for getting the device. So we had over 8,400 patients who were perceived to be at high risk for sudden arrhythmic death post-infarction. And we followed them for a year with a long-term follow-up being available out to a year, mostly through the Social Security National Death Index. One of the limitations of the paper is that government restrictions have clamped down on our access to that, but we have a follow-up for all those people. What we found was that for these individuals, 1.6% received an appropriate treatment, that is a shock from the life vest, after prescription. Of those, 1.4% survived and went on to definitive therapy one way or the other. So the take-home message of the paper is that if there's a patient for whom the physician is worried about for arrhythmic death, the life vest provides an opportunity for arrhythmia coverage in the waiting period before the ejection fraction can be reassessed to see if they are appropriate candidates for ICD implantation.
The highest risk, if I remember, was within the first 30 days, correct?
That's exactly correct. Of the 133 patients who received therapy, actually 100 did in the first 30 days. And the mean time to delivery of first therapy was 14 days.
Now, in the case of these particular patients, what did they teach us in terms of who are the appropriate patients for a wearable defibrillator?
That is the conundrum in the study.
Exactly.
And the Dynamite and Iris studies both showed that implantation of a device early post-infarction did not improve survival. And although arrhythmic death was decreased, this was exactly counterbalanced in both studies by non-arrhythmic cardiac death. And I emphasize that it's non-arrhythmic cardiac death because early post-infarction, it's not cancer or strokes that will kill. It's heart failure or sudden death. The patients in Dynamite and Iris are exactly the patients that physicians worry about. In Dynamite, actually, the mean CK release was over 2,000. The ejection fraction was in the mid-20s. I think 70% had anterior infarction. So these are just the folks we worry about.
Exactly.
And so who in that group that has a low ejection fraction would you pick out to deem at high risk? And I think for many of us, it's the patients with non-sustained arrhythmias that we pick up on monitoring. So to give you an example of a patient that might be a candidate, one of my patients, came in with actually a cardiac arrest, inferior infarction, got immediately revascularized. His right coronary was occluded, perfectly opened, other vessels were normal, ejection 40, and on the day of walking out of the hospital, had a 19-second run of VT. So here's a guy that has an ejection fraction that is sort of okay.
Right.
Chances are he's going to get better in the next month. Had a non-sustained arrhythmia, and that wasn't just 3 beats, and gave him a vest. And at 30 days, no event had been recorded on the device. His ejection fraction was 55%, and as such, he did not fulfill the requirements or really the appropriateness for ICD implantation.
But in that interim, there was some confidence, and I bet the patient felt better knowing that there was something there.
Yeah, absolutely.
Backup strategy.
Absolutely, because you truly have a life vest in every sense of the word and a bailout strategy, but there's also an end in sight that this is not something you're going to have to wear for the rest of your life.
Right, which is very important. So this is in the combined Thanksgiving issue. It's the 19th, 26th of November 2013, and it's Jack, it's Epstein et al. Please take a look at the paper itself and the accompanying commentary. For CardioSource World News, I'm Rick McGuire.